Good afternoon. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation. And on behalf of NIHCM and the American Academy of Pediatrics, I'm pleased to welcome you today to this webinar, Patient-Centered Pediatrics, Coordinating Care for Kids. The patient-centered medical home model has emerged as a core component to reforming physician payment in order to strengthen and reward primary care. The number of medical home initiatives and patients served by these efforts has grown significantly in recent years, and they range in size and scope. While most have focused on adults with chronic conditions or children with special health care needs, there's also a growing number of initiatives to coordinate care for all children, with a focus on improving immunization and well visit rates, reducing avoidable emergency room visits for children with asthma, and even preventing obesity. Our partners at the AAP have been leading medical home implementation efforts for many years, and recently AAP President Dr. James Perrin emphasized the importance of the medical home to alleviating two significant threats to the promise of a child: toxic stress and poverty. Today we're joined by an excellent panel of leaders who are all at the forefront of increasing access to coordinated high-quality care for children and their families across the U.S., and today we'll learn more about their medical home efforts spanning both the public and private sectors. Before we hear from them, I'd like to thank NIHCM's President and CEO, Nancy Chalkley, as well as the NIHCM staff who helped to convene this event today, including Caitlin Ellis, Katie McDonald, Carolyn Myers, and Amanda Parker. I'd also like to thank and acknowledge the AAP staff who helps coordinate today's event, including Ghazi Onima Melton, Wendy Chill, and Dan Walter. You can find biographical information for all of our speakers along with today's agenda and copies of the slides on NIHCM's website, www.nihcm.org. I am now pleased to introduce our first speaker, Dr. Ann Edwards, Chair of Pediatrics at Park Nicollet Health Services, an integrated large multi-specialty group and pioneer ACO in Minneapolis, where she also practices general pediatrics serving an urban immigrant community. She's chair of the AAP Committee on State Government Affairs and a liaison to the Committee on Federal Government Affairs and Subcommittee on Access. Dr. Edwards is a past president of the Minnesota chapter of the AAP and currently serves as the chapter's policy committee chair. Dr. Edwards joins us today to share an overview of the importance of care coordination for children and how states are implementing many pediatric medical home efforts. Dr. Edwards?
Thank you. Thank you very much for that introduction. As stated, my portion of the discussion today is really to provide an overview, and it certainly will be somewhat of a brief overview because, as was suggested, there are many, many efforts ongoing surrounding the medical home and care coordination throughout the country. And so my goal is to really talk about some of the general improvements within healthcare systems to improve health outcomes through the use of integrated and coordinated care. And where we really start is with the triple aim, and I think that this will be familiar to many people on the call. Well, a lot of attention these days is around coverage and benefits. Really, this is the core of where we start to transform care. And as a starting point, to remind people, the triple aim of healthcare reform is to, one, improve the patient experience of care, and this is really about meeting patients within the community. Secondly, to improve overall health, and that is really by increasing connections and collaborations between healthcare, public health, and other sectors within the communities. And then finally, to also reduce costs. And this is really focused on improving the efficiency and effectiveness of services. So many healthcare transformations are currently underway that have the goal to achieve this triple aim, to improve care and health outcomes while reducing costs. So really, as we start to look at this, there are several means by which health system transformation is happening. Integrated and coordinated care includes a range of activities that link individuals and families to services in a more holistic manner. And this really starts as relationships between specialists, but really now as we move forward is beginning to link to specialists outside the traditional medical forms. Caring for children is almost always conducted in the context of the family. So coordination is about helping to connect a child to needed services while also assisting the entire family to provide for their children's care. And this is where family and patient-centered medical homes really start to take form. And finally, accountable care organizations attempt to make care coordination easier not only for patients and families, but also physicians. So let's first talk about family and patient-centered medical homes. First introduced in 1967 by the American Academy of Pediatrics, the term initially talked about the Center of Children's Medical Records. This, over the years, transformed into more discussions about children and youth with special health care needs. But over time, it has really evolved to describe primary care that is accessible, family-centered, coordinated, comprehensive, continuous, compassionate, and culturally effective. And hopefully many of you have already heard of these terms to describe the medical home. In a family-centered medical home, the pediatric care team works in partnership, and that's a key word, in partnership with a child and the child's family to assure that all the medical and non-medical needs of the patient are met. The team can help the patient and the family access, coordinate, and understand specialty care, but also educational services, out-of-home care, family support, and other public and private community services that are important to the overall health of the child and to the well-being of the family. As we continue to look at care coordination, we need to consider how it functions within the family and patient-centered medical home as a bridge across various systems, involving pediatricians and other physicians, but again, schools, Head Starts, and community-based organizations. We get to key concepts of care coordination when we consider how it might be comprehensive, how it continues to be patient and family-centered, and how there is always appropriate follow-up to ensure better health outcomes for children. And what's important as we continue our discussion is how this all works through a feedback loop, where the medical home is a starting point into other services that then continue to link back in that bidirectional manner. So some basic goals of care coordination. They should be based on patient and family-centered approach that stretches beyond the primary care physician. Note that these goals are addressed through the elements of the triple aim: less fragmented care, which serves to improve health outcomes; less duplication leads to lower health care costs; and an improved experience, which is good for all, including those providing the care within the team of the medical home. Now, in spite of the desire of pediatricians and other physicians to coordinate care and be a medical home for their patients, there can be barriers. As we go out and work with practices, many express that they do not have the time or resources to dedicate to care coordination. Historically, physicians have not been paid for the provisions of these services, such as assessing the need for long-term services or time spent developing and implementing patient-centered care plans or coordinating care across multiple providers. Some people will describe this as living in two worlds. There's a great desire to do what is right, but at the same time, there has not been payment to recognize this. So this discussion now moves forward to how are we beginning to achieve this with the barriers previously noted. There are various ways health systems are moving forward to address this. For example, the Centers for Medicare and Medicaid Services, Medicaid, has started to take steps to guide state Medicaid offices on the importance of care coordination and providing states with various strategies to strengthen its use in an effective way. And you will note some of these. They are building care coordination into provider standards for medical homes, supporting primary care providers with care coordination entities, building care coordination requirements into contracts with managed care organizations, and implementing multifaceted interventions to improve care coordination across systems. How else can we start to address these barriers? We can also start by asking the questions. How does one identify those who would most benefit from care coordination, including but not limited to children and youth with special health care needs? And how do you begin to measure care coordination? We recognize that the Pediatric Quality Measurement Program, which is monitored by AHRQ, the Agency for Health Research and Quality, has developed some very specific measures. In specific, the CHIPRA, Children's Health Insurance Program Reauthorization Act, recognized it important to look at core measures, but also to enable centers of excellence to develop further pediatric measures. At least one of these centers is looking at the very issue of care coordination, specifically looking at care coordination for children with medical complexity and for children with social complexity, including those who are healthy and those with non-complex chronic conditions such as asthma. Additionally, measures are being developed to look at transitions between sites of care and the quality of these transitions. And of course, work is ongoing to further develop models to identify children with special health care needs, but also to identify children who may have social complexity. And then, of course, as we begin to develop these measures, how do we continue to use these measures to promote continuous quality improvement, to promote and support ongoing care coordination? Another important step in addressing the need for care coordination to improve health outcomes was the ACA, which included a provision that created medical homes in Medicaid. For the first time, the ACA provided a federal definition of medical home, referred to as health homes in the law. Under Section 2703 of the ACA, states can develop optional Medicaid health homes for Medicaid beneficiaries who have chronic conditions. Under the law and subsequent regulations, CMS indicated that it wants healthcare providers to operate under a, quote, whole person, end quote, philosophy. Again, getting beyond just the chronic conditions. Therefore, physicians and other non-physician clinicians, as well as community health workers and care coordinators, begun to integrate and coordinate all primary behavioral health and long-term services to support and treat the whole person. The law specifically indicates that health home services include comprehensive case management, care coordination, comprehensive transitional care and follow-up, patient and family support, and referral to community and social support services. Again, you might recall some of those keywords from the previous definition of the medical home. Federal regulations require that all providers report quality measurements of medical homes to the state. And states are required to report utilization, expenditure, and quality data to CMS for evaluation. Additional federal guidance also encourages the use of health information technology to link all of the provided services to increase efficiency and coordination. To date, 16 states have approved Medicaid state plan amendments to implement health homes. Another way the ACA works to move health systems forward on greater care coordination and integration was the creation of the Center for Medicare and Medicaid Innovation. The purpose of the Cmmi, as it is called, is the development and testing innovative payment and service delivery models to enhance the quality of care while reducing costs. We'll discuss CMMI grants a little bit later. CMMI has been providing states and other stakeholders with grant funding to do just that over the last few years. Much of the work being done with these funds includes care coordination as well as work with accountable care organizations. So how do accountable care organizations fit into our discussion? Accountable care organizations help to provide the infrastructure and incentives needed to facilitate collaboration across different types of providers and organizations. On this slide, you see how CMS defines accountable care organizations. Again, you see the elements of the triple aim. The goals of delivering high-quality care as well as high-value care, that is, spending healthcare dollars more wisely, are achieved in part through care coordination. ACOs, in addition to providing infrastructure and incentives for these activities, can also align resources to meet both the clinical and coordination needs of the patient and their families. ACOs can also help to overcoming the barrier of payment that was discussed earlier. They reward physicians who are able to manage the care of their patients and meet certain quality measures, including things such as reducing hospital admissions and emergency room visits. A recent study of ACOs by the National Academy for State Health Policy describes a range of strategies taken by states to drive value-based payment mechanisms aligned with accountable care principles. The 18 states discussed in the report are implementing various strategies in Medicaid or in state employee health programs. The 4 areas the report focuses on are financing ACO models, developing state standards for ACO certification, fostering the creation of community-based organizations, such as networks of state-run coordinated care entities, as in Oregon or Alabama. In Alabama, the state was divided into regions and community-led regional organizations that are charged with coordinating the health care delivery to Medicaid patients. And finally, redefining managed care organization contracts to align with these ACO principles. Of the 7 states supporting their own ACOs, Arkansas, California, Iowa, Maine, Minnesota, New Jersey, and Vermont, only California is not Medicaid-based. Rather, it is for the California Public Employees Retirement System. As you note, 13 of these states involve pediatric populations. Another example is Minnesota's Integrated Health Partnerships demonstration. 9 ACO contracts were awarded to various providers and partner organizations, including networks of clinics and hospitals, FQHCs, and 12 counties and local provider groups, which do include pediatric populations. 3 states are developing a regulatory framework, Massachusetts, New York, and Texas. And creating a regulatory framework will help to facilitate the formation of ACOs and promulgate common standards for design and performance. 8 states are creating community-based organizations or redefining managed care contracts to better reflect ACO principles. These states include Alabama, Colorado, Hawaii, Illinois, Louisiana, North Carolina, Oregon, and Utah. As stated on the previous slide, there is much state-level work happening regarding ACOs. State Medicaid programs have also been moving forward with developing other models for increasing coordination. In addition to states implementing accountable care models, many states are also beginning to pay for patient-centered medical home programs and have had Medicaid state plan amendments, as previously described. Let's also talk about the state activity in regard to CMMI grants and their role in healthcare system changes. CMMI provides states with grants to move their work of developing innovative healthcare transformation forward. The State Innovation Model Initiative provides support to states for the development and testing of state-based models for multi-payer payment and healthcare delivery system transformation. The projects focus on people enrolled in Medicaid, the Children's Health Insurance Program, otherwise known as CHIP, as well as Medicare. Almost $300 million have been awarded to 25 states to design or test their models for improving health and payment and delivery systems. A majority of the funding in Round 1 was for states to test their innovation models in 6 states: Arkansas, Maine, Massachusetts, Minnesota, Oregon, and Vermont. All 6 states have requirements for practices that participate in the model to be recognized as a patient-centered medical home in the state. So as I mentioned, Minnesota, my home state, is a recipient of the CIM grant. And the overall goal is really the triple aim: to improve health, provide better care, and decrease costs. The grant in our state is really expanding on an existing ACO program, including the IHPs previously described. Essentially, it's expanding patient-centered, team-based care through service and delivery and payment models to support integration of medical care, behavioral health, long-term care, and community prevention. It really depends on prior reform models to support secure exchange of clinical data, statewide quality reporting and measurement for providers, and strong systems for coordinated care through our previously described healthcare home model. The goals are 4. 1, to test how to provide and pay for value-based care by expanding ACOs to multi-payer systems. Secondly, to develop common measurement across payers, improve clinical data exchange at the clinical provider level, and align payments and risk adjustment. Thirdly, to really support practice transformation. And this is really to model the best of the best through statewide learning collaboratives and shared learning through short-term learning seminars. Practice facilitation and practice transformation grants, especially for smaller practices and rural practices, are promoted. We're looking to increase healthcare home certification from nearly 50% to 70% and expand to what we call behavioral health homes. And we're looking to also support an emerging workforce and look for new team members to the medical home. Finally, we're actually moving the ACO into something we call accountable communities for health, recognizing that health is really much outside the borders of our clinic walls. Accountable communities for health require a community-led leadership team, but also to include an ACO. They develop community-based care coordination. They must have a population-based prevention component, and all accountable communities must participate in measurement. So overall, the things we've discussed today provide an overview of what's happening around the country to promote and provide care coordination and encourage the use of family and patient-centered medical homes. This is an issue that is constantly moving forward and changing as different models and programs are implemented and evaluated. We can expect more changes in the future. Listed here are some resources from the American Academy of Pediatrics, and please be sure to visit the National Center for Medical Home Implementation website for additional information and resources. Thank you.
Thank you so much, Dr. Edwards. We really appreciate your leadership and the AAP's leadership on medical home implementation, and thank you for that overview of understanding all of the current activity at the state level. We will now turn to hear about 2 private sector efforts to coordinate care for kids, and our next speaker will be Dr. Stephen Peskin, the Senior Medical Director, Clinical Innovations at Horizon Healthcare Services, Inc. His expertise encompasses physician leadership, medical delivery management, performance improvement in healthcare, and payment innovation. Dr. Peskin's primary responsibilities at Horizon Healthcare Services focus on the patient-centered medical home program that's transforming the relationship with primary care practices in New Jersey. He leads the collaboration to improve population health, enhance patient experience, and mitigate the cost of care. We're so excited to have him with us today to share Horizon's work to advance payment innovations and improve pediatric care and pediatric health. Dr. Peskin?
Thanks so much, Catherine, and thanks to the National Institute for Healthcare Management Foundation and Dr. Edwards and the American Academy of Pediatrics. We certainly borrowed liberally from the American Academy of Pediatrics information, including help from Fran Gallagher, who's the executive director here in New Jersey, as part of our Pediatric Advisory Board to create our Pediatric Health Home here in New Jersey that we kicked off in January of this year. So looking at where we've been on this about 4.5-year journey, and again, as Dr. Edwards very much focused around the triple aim, and really there's a quadruple aim. The fourth part of the aim is higher level of healthcare professional satisfaction, whether she be a physician or he be a nurse or an advanced practice nurse, medical assistant. So we very much look at that as part of our charge here at Horizon to improve healthcare affordability, and also create a more collaborative environment for managing healthcare effectively and affordable. We have within our patient-centered programs, our foundation program was the patient-centered medical home for adults. We've been ongoing with that for 4 years. And at the bottom of that list, and I'm joined by Eva Wasserman, who's going to take a few minutes to talk about our obstetrical episode of care program, which is near and dear to folks on this call as well, the beginning of life. And so we started with 5 practices in major joint replacement, and then we moved on into many other episodes, including obstetrics, which Eva will talk about. And then within those bookends, I think it might have advanced the slide a little prematurely. That's all right. We have the Comprehensive Primary Care Initiative, which is really a build on the adult patient-centered medical home. Dr. Edwards mentioned the Center for Medicare Medicaid Innovation. So we were fortunate here in New Jersey, along with 6 other regions, to receive the Comprehensive Primary Care Initiative, a 4-year program, which again harmonizes Medicare fee-for-service with ourselves and 3 other payers around the principles of person-centered, team-based, comprehensive care. The pediatric program we'll talk about in more depth, and then accountable care organizations are another important part of what we do. We now have 14 ACO partners, which is really a kind of a broadening or an extension of the principles of the medical home and a system of care. You can see on the next slide from our rather modest beginnings, and if you moved over 1 year earlier in 2011, where we had 8 primary care practices and 5 orthopedic partners and our major joint replacement. 2012, a fairly modest footprint. 2013, taking us all the way now to this year, where the map of New Jersey and the major population areas are dotted with many patient-centered practices, adult, pediatric, ACO partners, and episode of care partners. And again, I'll let Eva talk in just a few minutes about what we're doing specifically in obstetrics around episode of care. Our guiding principles really are 5. Care planning and coordination, and we'll talk about that specifically as it relates to our pediatric program. And I would add another C there in addition to collaboration, which is our mantra here, and that's culture. Some of you may be familiar with a book that was introduced to me by Marcy Nielsen, the executive director of the Patient-Centered Primary Care Collaborative, the PCPCC, where I'll be speaking in a couple of days in their annual meeting, and that's culture. Kathy Sorensen and Kurt Kaufman talked about culture eats strategy for lunch, and it's absolutely vital that we take a culture here at Horizon which is collegial and collaborative, and we infuse that with our practices toward patient-centered care, toward team-based care, toward having individuals operate at the top of his or her certification, whether he be a medical assistant or she be a nurse or a physician or an advanced practice nurse, and the back office part of medical practices as well. Data and technology, we place a lot of emphasis and attention on exchanging data with our practices. We'll talk about that as it relates to pediatrics, which right now is a bit of a lighter touch than what we're doing in adult medicine, but we still are exchanging some information with pediatric practices. Very important, obviously, to engage, educate, empower patients, the notions of shared decision-making. We teach motivational interviewing, teach-back principles. We have a lot of tools that we provide to our clinical partners on a medical home is not a nursing home or a mobile van, but is actually a place where you can expect to get comprehensive care, the right setting at the right time. We do a lot of education information, and it's not just a unidirectional in our program support that is in that oval where we have our playbook. A lot of our education is being done by our clinical partners. So when we do webinars monthly, it's not Horizon or outside experts from Minnesota or Colorado or Oklahoma or anywhere else, though we work with folks outside of New Jersey. It is our thought leaders talking about how they're dealing with low acuity, non-emergent, ambulatory sensitive ER visits, how they're inculcating team-based care, how they're working on building their medical neighborhood. And of course, as a payer, we focus a lot on payment reform, and I'll talk about that in more detail as it relates to our pediatric program. So again, we've talked about improving care coordination, delivering the right care in the right setting at the right time. That's very much a cornerstone, and I'll get into in a minute how we're reimbursing for care coordination and specifically around care planning for that minority of patients in a pediatric practice that are high risk or chronic. Talked a bit about patient engagement, the importance of data, and we're constantly evolving ourselves, working on our bidirectional data exchange with our practices, and payment transformation going from fee-for-service toward much more fee-for-value. In our pediatric model, we are paying for, at the number one position, you can see we're paying for care plan development, so that's an initial payment of $125 for the initial care plan for a person with autism spectrum disorder or type 1 diabetes or asthma or depression or whatever that situation might be for that young person. And then updates to their care plan we're paying for a maximum of twice a year. Horizon is providing support to our pediatric partners with trained RNs that are on my team that are dedicated to coaching and to improving practice workflows, workflow redesign. Certainly we have our thought leaders here in New Jersey, and again, we will go to Dr. Stoller or others and Dr. Schlitt to help them to help their colleagues. And the pediatric community here in New Jersey is highly collaborative, which we appreciate. We pay for quality, and so that quality is largely based on a set of measures that will be very familiar to the folks on this call, which I'll get on the next slide. And then we also have one efficiency measure, which is related to emergency department visits. In contrast, in our adult model, we're looking at generic dispensing, which is already really, really high in the pediatric program. We're looking at inpatient admissions per 1,000, which are already very low in the pediatric program. So it's hard to improve on things that are already quite good. And then we also look in our adult program at total cost of care is our fourth measure. So in pediatrics, we're using just one utilization metric, as you'll see on this next slide, ER visits per 1,000, where we think there's still an opportunity to see some improvement in that particular metric. On the quality side, weight assessment and counseling, nutrition, physical activity, children and adolescents, childhood immunization, appropriate testing for children with pharyngitis, appropriate treatment of upper respiratory infections, which partly ports over to a cost measure, but as we know, with antimicrobial resistance, very important not to overprescribe antibiotics. Development of screening tool used in the practice, child and adolescent access to primary care, ages 7 to 11, access for children, young adults, adolescents, 12 to 19, and adolescent immunization. So those are our quality measures that we benchmark from the Health Effectiveness Data Information Set, aka HEDIS, and this is how we define the utilization measure for ER visits per thousand, which looks at both how the practice is doing against itself and also how the overall network here in New Jersey is trending to achieve a outcomes-based payment for this efficiency measure. And I think that may be, is that my last slide, Eva?
I think so.
And now I'm going to turn it over to Eva just to give a very, very high-level overview about an exciting program that we launched just this year, our obstetrical episode of care program.
Thank you, Stephen. I'm Eva Wasserman. I'm a transformation coach on the episode of care team. It is very exciting. It's another way of extending that initiative to incent specialists to coordinate care. The specialists, we call them more of like the orchestrator. They're helping to attain that triple aim of reducing healthcare costs by taking a look at an episode like pregnancy and trying to avoid duplicative services that can arise. Also, hopefully improving the clinical outcomes, which is another aim, and in pregnancy looking at reducing, the goal would ultimately be to reduce C-section rates, and they can do that through patient engagement and education, and sometimes it's unavoidable, but usually there's some education that can go in there. And also, we share the savings with these specialists on the episodes. So the pregnancy episode begins with a pregnancy, obviously. It takes a look at the 36 weeks prior to the admit date for the delivery of the baby, and then also 8 weeks after the discharge date. And that would be considered the episode that they're trying to coordinate that care in. And so by doing these initiatives, we're hoping here at Horizon that obviously, we're engaging physicians, pediatricians, specialists, primary care physicians to really help coordinate the care, and we're incenting them by sharing the savings. Well, that's about it.
Thanks.
Thank you both so much. Your impact and collaborations across New Jersey are truly impressive, and thanks for sharing your experience, and we look forward to hearing more as you continue in your work with both the pediatric and obstetric populations. Our last set of speakers will be describing WellPoint's pediatric learning collaboratives and their partnership with the AAP. Joining us today are Crystal Kozer, who manages the Pediatric Learning Collaboratives program for enhanced personal health care at WellPoint, Inc. She joined WellPoint as a project manager for care delivery transformation after several years as a healthcare consultant. Joining her is Neha Patel, the manager for community transformation in the Western region at Anthem Blue Cross Blue Shield of Colorado. She's been with Anthem for 7 years and has been with the Enhanced Personal Health Care program since its launch in 2013. They will be sharing their work to support providers and pediatric members through these collaboratives developed with the AAP.
Thank you, Catherine. This is Neha. Good afternoon. And today, Crystal and I want to thank you for allowing us to come and share our story of a collaborative experience. Today, we would like to share briefly about our program, how we were able to identify the needs of the pediatric population, and to share the collaborative approach we took to meet that need. We're going to discuss the impact and our plans ahead. The objective of the WellPoint's Enhanced Personal Health Care program is to promote change in the current structure. by supporting the transition from a fragmented and episodic healthcare delivery system to a patient and family-centered system, which is accountable for substantially improving patient health by making a significant investment in primary care. This allows primary care providers to do what they do best, which is managing all aspects of the patient's care. Our program is providing primary care providers with tools, resources, and meaningful information that promotes access, shared decision-making, proactive health management, coordinated care delivery, adherence to evidence-based guidelines, and care planning built around the needs of the individual patient, which leads to improved quality and affordability for providers and their patients. Our program supports the redesigning the current payment model to move from that volume-based to value-based payment, aligning financial incentives and providing financial support. All of this allows for activities and resources that truly focuses on care coordination, individual patient care planning, patient outreach, and quality improvement. Our enhanced personal health care program's objectives support a patient and family-centered model. The program is designed to meet the needs of an overall population of adults and children, and we understood the needs within the structure of our pediatric providers would require unique attention. What we're going to discuss today in detail is to review how our learning collaboratives were fashioned to support our littlest members. As you can see in this graph, our program covers a large number of providers. 42,500 plus providers covers 15 states. And as you can see, roughly 30% of our providers serve a pediatric population. So even though the patients might be small, they are not small in numbers, which create an impetus to ensure we find a way to meet their needs. And that's not 30%, that's closer to 45%, I apologize. Can't do my math. So our program really relies on data, which is claims-based, of course, that we share with our providers to impact outcomes in their patient population. For the adults, data really supports finding focus on target conditions such as diabetes, COPD, heart failure, but for the pediatric population, which tends to generally be healthier, using data becomes a bit more difficult. And caring for the pediatric population also requires unique needs, such as managing parents, schools, and other community influences that can be supportive and or lead to barriers. Starting young allows for more opportunities for prevention and education, which takes creative approaches to ensure that learning takes place. As a part of our program, given that data would drive some change, but noticing a clear gap, we needed to find other ways to support our pediatric population. Creation of the Pediatric Learning Collaborative was one method we implemented where experts from the field nationwide came to share their best practices, lessons learned to meet the specific needs of our pediatric population. Crystal is now going to take us through our process of creating and implementing the Pediatric Learning Collaborative.
Thank you, Neha. I am Crystal Kozar, and I'm the project lead for the Pediatric Learning Collaborative Initiative. And I've had the honor of leading the program through 2014 to become the robust program that it is today. So this slide outlines for you our goals for the program. As Neha mentioned, we identified a gap in pediatric support of our providers, so we created the Pediatric Learning Collaborative program to implement national educational opportunities to support these practices as they address the most critical health conditions affecting the pediatric population, thus closing that gap she mentioned and supporting patient and family-centered care. We strive to prepare a high-quality curriculum that provides best practices and support for our providers to help them control hospitalization rates, improve patient dialogue, reduce the rate of preventable diseases, and provide quality educational resources to their patients. because as you know, relevant and current information is always appreciated by busy practices. Central to this model is the relationship we've built with the American Academy of Pediatrics and the support that we've received from other national healthcare leaders. To achieve these goals, we created a program structure that allows a core internal leadership team that includes physicians to provide guidance and content review for each session. We've also created sub-teams specific to each topic that we will cover, and we work directly with our speakers and together gather the most valuable resources and create quality presentations. Initially, when we were ramping up the program, leadership prepared our agenda for 2014, and it included immunizations, well visits, asthma, and pediatric obesity to kick us off. But we found that as our field teams were querying practices for critical topics, we received many requests for behavioral health to be added as a topic for 2014. So we added behavioral health to the beginning of the year since the demand was so great. So far in 2014, we've held 15 very successful virtual webinars covering those critical topics. And between attendance at live events and viewed recordings of our webinars, we've had more than 1,300 attendees overall. This slide demonstrates for you the structure of each session, and I don't need to spend much time, but I do want to point out a few details about our sessions. Each pediatric session is comprised of a virtual presentation from our subject matter expert, and it includes audience polling throughout, and a 15 to 20-minute Q&A session at the end, along with a post-session survey. As the event is ending, we make presentation slides available for download, along with useful resources in a customized resource sheet for each session. We've received really positive feedback on the customized resource sheet for these events from our practices because they don't always have the time to research best resources with all the information that's available to them today. So they appreciate us doing this research for them on the front end. And every one of our sessions is recorded, and the recordings are made available on each state's Enhanced Personal Healthcare website. These pediatric educational events would not be possible without the support we've received from many national organizations and educational institutions. This collaboration allows us to stay in tune with the needs of our practices and provide curriculum that addresses their greatest challenges on the most critical topics. That is why we're so successful in creating these valuable educational events. We've been able to partner with highly regarded subject matter experts from around the country. I also want to highlight that one of our partnerships in 2014 was with one of our pediatric practices from Virginia. This practice presented on how pediatric obesity has affected their practice, including lessons learned and the steps they've taken to address this national dilemma. Because peer-to-peer sharing is impactful, and we do hope to include more practice partnerships in the coming year. So this slide is a visual representation of the many valued partnerships that we've built in 2014. And I also want to point out that while we've partnered with our Virginia practice in addition to these amazing national organizations, we've also been supported by internal groups as well so that we can enhance each and every presentation with health plan information that would be valuable to practices. We've had presentations from our internal disease management, care management, marketing, multicultural health, and behavioral health programs, in addition to our very own Enhanced Personal Health Care Delivery Transformation team. So in the end, we strive to positively impact our practices, and we do check in with them to determine if we've hit the mark for each presentation. When surveying practices at the end of each session, we ask attendees what information they found to be the most helpful and what interventions they can implement within their practice. These are some of the responses that we've received from our practices, And you can see in the first column, practices benefit from a review of statistics and resources because we can assume, once again, that they have the most current information handy at all times. They do appreciate tips and tricks and suggested areas for improvement of practice workflows and patient care strategies. They also enjoy our practice suggestions and a little encouragement from us from time to time. In the second column, you can see that providing the most current and relevant information, our practices are inspired to advance their processes and approaches to patient care and better engage parents while implementing improved strategies, tools, and guidelines. And the last bullet, number 5, is highlighted because those interventions are from responses to our recent Pediatric and Family Practice Survey, which I will discuss in more detail in a few minutes, while the other responses were received throughout the year from routine polling questions. On this slide, I wanted to share with you some quotes from our practices demonstrating their excitement around the sessions that we've held to date. We're very fortunate. Our practices are very engaged around these events, and they do share their feedback with us. So now with 2014 under our belt, you may be curious about our plans for the coming year. Because we know that practice priorities have changed, or may have changed in the last year, we prepared a practice survey and circulated it through our field teams to our pediatric and family practices to see where we can best support them in 2015. The survey underscores the importance of bidirectional communication and allows practices to become invested in the curriculum as it is being developed. And we do hope to have all our practice input by the end of November, and then we can begin planning for the coming year. 2 areas we're consider piloting in 2015 is including practices with parent advisory groups so we can prepare events geared more towards families and offer them through these parent advisory groups. In addition, we've been piloting opening these events up to providers outside of enhanced personal health care through the American Academy of Pediatrics, social media channels, and outlets. And while survey responses continue to arrive on a daily basis, I can share with you that the top 3 topics that practices are interested in so far are transitioning patients from pediatric to adult providers, behavioral health, once again a top request, and also pediatric obesity. When planning our curriculum for 2015, we plan to continue to make the support needs of our pediatric and family practices under our patient and family-centered care model our top priority. In summary, this presentation outlines for you how WellPoint, in partnership with the American Academy of Pediatrics, is supporting better coordinated care for kids through improved practice support and education. Under the umbrella of Enhanced Personal Health Care Program, where we're creating a patient-centered system that is focused on value, communication, and quality improvement, our Pediatric Learning Collaboratives are a forum for us to connect with our practices as they strive to provide the best care possible to our littlest members. Neha and I would like to thank you today for your time and invite you to reach out to us with any questions or if you'd just like to discuss our pediatric program further. So thank you.
Thank you both so much for sharing your work and collaboration to help pediatric providers provide high-quality care to their patients and also transition to these new value-based payment models. We've had quite a few questions come in already and in advance of this event, so I know there's a lot of interest in learning from all of our speakers today, and we're excited to kick off our Q&A session. We have a diverse audience of healthcare decision makers, both providers, policymakers, folks from the business community, as well as government agencies at the federal and state level. At this time, our operator will explain how you can ask a question directly of the speakers if you're joining us by phone, or if you would like to join us by phone, the phone number is up on your screen as well. Otherwise, we will then go through questions that are submitted through the Q&A box. So I'll turn it over to Laurie at this point.
If you would like to ask a question at this time, press star and the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster.
Thanks, Lori. While we're waiting, I'll start with one of the web questions and then come back to you to see if anybody has queued up. We have a question for Dr. Peskin and the Horizon team. If you could explain a little more about, this is from Jean McAllister, if you could explain how you arrived at the payment for the care plan development and updates.
Yeah, we did some benchmarking. Importantly, we had and I referenced this but didn't provide a lot of context to the Pediatric Advisory Board that we created, which included several pediatric thought leaders in the state of New Jersey, 3 of whom were quite steeped in medical home and the activities of the American Academy of Pediatrics, 1 seasoned office administrator for a multi-site pediatric group, our executive director of the New Jersey chapter of the American Academy of Pediatrics. So that was the way that we came up with the payment, the specific number. Again, benchmarking and input from our colleagues.
Great,
Mary, do you have anything to add? I'm joined by a couple of my colleagues who just walked in a few minutes ago after wrapping up another webinar, Mary Akins and Lisa Kerrigan, who work with me closely on the model.
Thank you. Another question that came in for Horizon, and for readmissions or on the quality measures, have you assessed gaps in care by race, ethnicity, or zip code and identified opportunities for closing those gaps?
We have not looked at race, ethnicity, or zip code. Our efforts are focused around a practice, and a practice is defined by something called a 10. Some of you may be familiar with that number. This is not the Wizard of Oz 10 man. It is the tax identification number for that entity. Some practices have multiple locations, and they typically tend to be geographically clustered. So that would represent a zip code or a couple of overlapping zip codes, but we have not looked at race or ethnicity. Mary, anything to add to that on?
No, just that we provide to the practices the list of members of patients that we think are qualified to have their care plans done, but we also give the practices the opportunity to identify anybody outside of what we would have found through claims, so that they can make sure that they're providing that care to the patients who need it most.
Great, thank you. Lori, do we have any questions in the queue?
You have no audio questions at this time.
Okay, great. We have quite a few more coming through. This one is from Lisa Fowler, and I think, Dr. Edwards, you touched on some of the things being developed for children with medical complexity, but I'll read the question, and whoever wants to jump in. What specific programs, supports, and resources are available for children with medical complexity and/or children with chronic complex conditions? These are some of the most complex, resource-intensive children, but are not well supported by current healthcare systems.
So, I don't know where the question is coming from, and I'm wondering if that there are some innovative models throughout the country that are really looking at how to care for children with more of these complex needs in a coordinated manner and setting up specific medical homes. And it might be helpful if we have that contact information, we can reach out and connect people with specifics. I don't know if any of my colleagues from the Academy want to jump in as well.
Sorry, this is Dan Walter at the AAP. we do have a committee on children with disabilities here at the Academy, which also could serve as a resource. And I think, yeah, if we follow up offline, we can send some of the resources that we do have, which might be helpful.
Okay, great, thank you. A question for WellPoint related to your asthma virtual sessions. Do you address environmental triggers and/or racial ethnic disparities?
Yeah, we had 4 virtual sessions over the last 2 months, and environmental triggers were covered by almost every one of our speakers as we addressed how to actually control the environment of the child and creating a safe, clean space that is just for the child. And as far as racial disparities, demographic disparities, we did have a presentation by Cincinnati Children's where they covered a lot of that information as they address urban projects that they're working on as the leaders in reducing asthma-related readmissions and ER usage. So yes to both.
Great, thank you. This is both for the Horizon and WellPoint teams. Could you talk a little bit about, you both partnered with the AAP, the national and kind of the state chapter levels. How important have those partnerships been to your programs and also to kind of the buy-in of the providers that you're working with too?
Yeah, I'll start. This is Stephen Peskin. It's been immeasurably important. The New Jersey chapter of the American Academy of Pediatrics has welcomed us, and some of Lisa Kerrigan's team who's sitting here have attended recent meetings where we have been able to socialize our pediatric health home model and getting more practices interested. So it's been a very important relationship for us in advancing our medical home. With regard to the American Academy of Pediatrics nationally, again, some of the slides that Dr. Edwards presented we were using earlier on, and how we were thinking about the pediatric health home, medical home. So that was very valuable as well.
And this is Crystal Kozar from WellPoint. I would add to that by saying that partnering with the Academy helps us to support each other in our common goals and communicate very strong, important messages that we need to communicate across the country. We have buy-in from providers because we have the organization supporting us, and it also allows us to view these topics from a broader perspective than we may have as a health plan. When we have the Academy's research and support and our brainstorming sessions, it helps to frame the information and give us perspective that we use in building a more comprehensive curriculum.
Great, thank you. We had another question come in about sort of the patient-centered care and the, thinking about the family as being so critical to the care of these children. And this question asks, are there any aspects that help provide transportation to families that can help them get to centers for care and kind of get into some of those additional supports that may be required, especially for the Medicaid population?
I know with our, and this isn't pediatric medical home per se, with Horizon New Jersey Health, our Medicaid program, there are transportation, particularly with some of what we call the managed long-term support and services. These are some of the most vulnerable and most complex individuals. So I do know that there has been some consideration for transportation for some of those folks. Within our commercial program, we're not doing anything as it relates to transportation.
Other than identifying community resources that may already exist.
Okay.
And I would echo that's similar across the country. There may be other models that are looking at this issue of transportation more commonly probably in Medicaid agencies. But again, as we look at ACOs and other barriers to care, this is opening the dialogue for how do we interact within the community, either looking for existing community resources, as was alluded to, or creating mechanisms to provide access to care, either by providing that transportation or in other ways through other maybe home visiting programs or going out in the community.
Great, thank you. Lori, just wanted to check in to make sure there's no questions on the phone before I keep going.
You do have one audio question.
Okay,
Your
great.
first question comes from Ibrahim Cargio. Your line is open.
Thank you very much. This has definitely been very informative for our team here in Virginia. And one of the issues that we're running into is actually having pediatric providers partner with community organizations to provide that community-based care services. And I wanted to know if anybody has any tips or suggestions how we can really frame the issue to get that buy-in from the pediatric providers.
Do you want to direct that to a specific person, or anyone on the panel can jump in?
Just anyone on the panel.
Okay.
Maybe this is Ann Edwards, and maybe I'll just answer that broadly to say I think in the experiences that we have had, it is not so much a lack of buy-in in intent. I think that people see the value, and pediatric providers do. It's how do we take the first step to transforming the system and understand what the barriers might be. So very practically, and speaking more from my experience in Minnesota, it has been sitting down and having really open dialogues through learning collaboratives and shared learnings to say, you know, what has worked, what are the potential concerns or realistic barriers, and then looking for opportunities within some of these newer frameworks that might begin to break down those. And it's usually small steps as well, looking for some common ground and some easier reaches and that are wins for both sides. So thinking of places like schools and childcare might be some of those community-based organizations, again, not knowing exactly what you're thinking, that might have similar hanging fruit. And I don't know if other people want to jump in as well, but just some initial broad thoughts. And we'll be happy to talk offline more as well.
Great, thank you. Hope that was helpful to your question. Lori, do we have any other phone questions at this time?
You have no further audio questions at this time.
Okay. We have another web question from Stephen Cook, who asks, is telemedicine being used and paid for in any of these models, specifically, you know, being able to see the patient in their own home? And in addition to that, we also had some questions come in ahead of time, just you know, more about technology and the role of mobile health technology and electronic patient portals, and how can we help use these tools to improve care coordination?
So this is Mary. In our current pediatric models here at Horizon, we are not using telemedicine. We have engaged in that in pilot mode for our adult population, and certainly it's something that I think that you know is on the table for the future, at looking at how that best supports the vulnerable patient population that potentially you know has a more of a challenge of getting to a particular facility. As far as patient portals, again, we are not mandating anything, but certainly our practices are committed to the development of their technology and how that supports care coordination at a whole, and we as Horizon are continuing to engage in those discussions and how we can best support the provider community as a whole, including the development of an HIE and other things around that.
Great, thank you. Would anyone at Wellpoint or the AP like to comment on that as well?
This is Neha at Wellpoint, and one of the things that we are trying to promote, just like Horizon, is looking at sort of the telemedicine. We're working with a company, organization called Live Health Online, and working to get that into our markets and seeing which providers would be interested in using that type of service and seeing if they can get that set up for their practice to support telemedicine. And we're just working through the various state regulations, because every state is a little different, in what is allowed and what is not allowed via a telemedicine portal. So we are looking into that for sure. And then in terms of patient portals, having worked in the field with practices doing transformation, that has definitely been a very useful tool in communicating with patients, providing education, as well as just making it a little bit easier to get refills or questions, easier questions answered over the patient portal, and definitely have had a lot of feedback of the benefits of using a patient portal.
Great, thank you.
And just for all the pediatricians that may be on the line, there's a section on telemedicine, and so there is interest within the provider community as well. So another resource within the academy that people might want to look to, and again, learn best practices from their peers as well.
Great, thank you. We have another question from Joe Rust, and she's at the Riley Hospital for Children in Indianapolis, and she asked, what have you found to be the best practices to help coordinate care between the primary medical care home and multiple subspecialists who may be working with this population? Or any resources for additional information.
I think this is Mary again, I think one of the things that we have found very, very assistive in care coordination as a whole, whether it's in the adult or pediatric models, is the physicians engaging with the other physicians in collaborative care agreements. So really setting up the structures and the foundations and expectations for how they're going to work together. And we have any number of practices that have develop those relationships strongly, so that there's a comfort level that they're committed to the same goals for the patients. And I think those collaborative care agreements have been a tremendous structure for our providers.
Great, thank you. Another question submitted by Lisa Spector Dunaway. Are you aware of any pilots that have utilized home visitors associated with an evidence-based model as part of the patient-centered medical home? So home nurses or other providers making home visits.
This is Crystal Kozar from Wellpoint. I know that was part of the Cincinnati Children's Urban Study on asthma, where they implemented home visits to check on asthmatic patients and check on their environment. But that's really our only speaker to date who's approached the topic of home visits.
Okay.
There are some other, as we look in, and it probably goes back into maybe some nurse-family partnerships and home visiting programs that have started to look at maybe more at-risk moms prenatally and then bridging that over after delivery to continue those home visiting, again looking at families that may be at risk for everything from postpartum depression or other ACEs. So there is some emerging work that continues to happen in the context of medical homes as well.
Great, thank you. Kind of expanding on that question, we had a question come in about commenting on the increasing demand for primary care and the role of nurse practitioners and community health workers, and kind of what role do you see these practitioners having in the medical home, and what scope of practice changes are occurring or are needed to effectively utilize these providers in the medical home and really kind of leverage the pediatricians and kind of the other parts of the team in the medical home.
So that's a question that has lots of, we could have a whole nother webinar on new team members. I think I mentioned within our SIM funding in Minnesota, we're looking at how to build teams and include things like community health workers. And I think that the community health workers have been a model that have been used in chronic disease traditionally, but now are looking at within other communities how they might also bridge some needs, again, through that coordination back into the community, as well as talking to communities about the benefits of the medical home. So certainly this is an area that's being explored in how we look at things and improve coordination as we look at population-based health.
Great, thank you. We have a question from Christy Botts that regarding the behavioral health support, could you elaborate a little bit more about, it was, I think, touched on from several of the speakers about, integrating and coordinating with behavioral health, and can you talk about that and also how that support extends to the family regarding kind of education of the whole family about behavioral health issues?
This is Neha from Wellpoint, and I'm actually an LPC. I'm a licensed professional counselor as well. And one of the things I think whenever you talk about behavioral health, and especially with children, it's sort of a given that you have to include the family in that care planning conversation and the education conversation and the support conversation. And so I think any kind of integration program that is surrounding behavioral health into primary care, that part has to be a part of that conversation in ensuring that the team, the care team in the practice is, has enough resources and support to provide that level of education and or reaching out into the community to build those partners within the medical neighborhood to provide that level of support. I know that at Wellpoint we have behavioral health case managers who are part of our program who will do outreach to patients, and we take referrals directly from the physicians who can then provide that additional layer of support to those parents and to those kids to make sure that they're getting the support, the education, the resources to address their behavioral health needs.
Great, thank you. Any others on the panel like to comment on that? Okay. We have another question about improving care for children as they transition into adulthood, and we're curious if any of the speakers have any experience or thoughts on how we can, continue to effectively educate adult medical professionals and kind of ease that transition between, the pediatricians and and other providers to continue the coordination of care during that critical young adult time period?
This is Neha from WellPoint again, and I think, as Crystal had mentioned in our presentation, that's definitely going to be one of the areas of topics that we're looking to discuss in the next year, because it is something that has been brought up. I think, the age group of, 15 to 21, oftentimes, there's HEDIS measures about wanting to bring them in for physicals, and oftentimes those are the hardest. That's the hardest population to bring in to the office, and then let alone how do we transition them into adulthood, into adult providers from the pediatric providers. So I'm looking forward to us doing some of that work in the next year.
Great, thank you. I have a question here. I think it's for Horizon. It's referring to your obstetric programming, and we're curious if you could give a quick summary of what it means to be the transformation coach and how that, kind of your role in the program. I think that might have been Eva who was on the line. I don't know if she's still here.
Yeah, I'm still here. We have transformation coaches available in our programs for patient-centered medical home, the adult, the pediatric, also for the ACOs, as well as the episodes of care. We primarily have the same job function, and that is, helping those practices transition and transform their practice to be more patient-centered. So taking a look at everything from workflows to, just patient engagement, educating, how to educate the patients, what to educate them on, also looking at different data on how to help them and avoid complications with patients, whether they have a chronic condition or wellness and preventative appointments that they need to have, and also in episodes of care, educating, and hopefully avoiding complications during a specific episode, such as pregnancy, helping them educate patients, on how to avoid those complications.
Great, thank you. A question from Eric Levy, and I think this is maybe referring to something Dr. Peskin touched on. And perhaps he's asking, are there any other content areas in the care of children that are demonstrating the potential for cost saving? He lists as an example the decreased ER utilization and hospitalization that Dr. Peskin mentioned. And I know everyone's still kind of early in their efforts, but are you looking at any other content areas in this regard?
So this is Lisa Kerrigan. So I think that we have, again, we're new in the program. Our program just started at the beginning of the year. I think there's two takeaways. One is data-driven. We definitely, as you mentioned, have seen a decrease in utilizing the ER for those practices that are included in our program versus those practices that are not in our program. And it's a rather significant decline, which is great to see. I think kind of anecdotally, we've heard that the development of the care plans and sharing those with the parents of the patients that we're developing the care plans on has been very, very well received. Now, I think there's components of the care plan that we ask that the practices submit. We're not proscriptive in saying you actually have to have every single in our format this way. But what I think it is, it's a tool that allows a great conversation to happen between the care team in the physician's office, the patient, and the parent. And while these elements were probably being captured previously, I think having the conversation has been critical. And I think certainly longer term, that could have a significant impact on costs potentially related to whether it be inpatient admissions, ER visits, those types of things.
Great, thank you. We've had a few questions come in from Tammy Rich, who is a parent on the Boston Children's Family Advisory Council, their Patient Safety and Quality Committee. And she has several questions, so I'm just going to try to summarize them. But she's a patient advocate wanting to get information across on reducing fragmented care to kids with complex care. And she has a few questions about the care plan and how those care plans are updated, how the parents are involved, and then she has a longer question here about, how they kind of grow along with the child, especially as they turn 21, and just, making sure, that care continuum really continues with the child.
So this is Mary. Awesome questions. And I think the answer is it's still very much in development. We know that pediatricians have been practicing great medicine for a long time, but putting these into formal care plans is something that the practices are learning. And how often they are being updated, how they move with the patient is determined at this point by the practitioners that are providing the care. So again, we as Horizon are not being prescriptive about how they do that, but rather opening it up to care plans are an important component for patients who have complex conditions, and then working to develop the best practices amongst the practices that are participating in our programs and sharing that across the practices so each can learn from one another, and including, again, obviously the academy in those processes as well. And I think I saw also there was a question about who paid for the care plan within Horizon. It is Horizon that pays for the care plan.
Thank you. Would any of the other speakers like to comment on their experience?
This is Anne, and this is using my experience in Minnesota with work within the medical home. I think that I can't underscore the importance as we look at system changes and really moving forward on this element to have parent partners involved at the table at every key step. That has been extremely valuable and really guiding in Minnesota. Specifically around care plans, I can speak that our parent partners and programs like Parent to Parent are really teaching parents how to maybe advocate and ask for the right things and partner with the clinicians in really a teaching collaborative process so that we all learn together at the same time about what we might need or want as medical providers, but more importantly what the family really needs and wants as part of those care plans. So I think there's great opportunity to have parents work together to provide that guidance in teaching collaboratively to families.
Great, thank you. We are approaching the end of our session, so maybe I'll summarize a few questions that came in and just ask speakers for some closing thoughts about kind of the future of children's health. And we had a few policy questions regarding kind of the uncertainty for the future of healthcare coverage for children and families, and a lot of changes occurring in recent years and potential future changes with funding for the Children's Health Insurance Program being uncertain as of next year. What do you think this means for the future of pediatric medical homes, and how, what are your thoughts in terms of what's necessary to continue to ensure that children have access to coordinated care in the years ahead?
This is Lisa from Horizon. We are definitely expanding our pediatric program in 2015. We started out rather on the small side just to understand and get the experience with working with the pediatric practices. Another thing that we are developing here in New Jersey is we are having a product offering that is patient-centered driven. So with that expansion, the development of these new products will definitely focus, the product itself is focused on patient-centeredness, so there is a benefit differential for members or patients that choose a patient-centered program as their primary care. So I think that will assist us to develop and expand the program. From today's standpoint, because it is a new program, I don't want to call it a pilot as of this year, but it was so new in infancy. We are developing different ways to collect information, exchange information with practices, and as we get more practices in the program, we'll definitely expand that, similar to what our adult program is, whether it would be a data exchange, and Mary had mentioned the HIE. That's certainly somewhere where that we expect to move in the future. We're not quite there yet, but we will continue to strive for that.
This is Ann, and maybe just to jump on the end of that, this is when the advocate comes out of me, and I say that we all need to stand and be present and really share these success stories and make the case for why the future is so important for all of us, and it's really important that we promote children's health to have an optimal future.
Thank you. Any others at the AAP or the WellPoint team like to share any closing thoughts?
This is Crystal Kozar from WellPoint. I would just close by saying, we will continue to support practices year after year by providing patient-centered medical home tools, additional customized curriculum based on feedback we receive from practices, maintaining that bidirectional communication. And the beauty of what we do is that our curriculum can be adjusted to meet practices where they are, to respond to what we're seeing in data, respond to changes in any healthcare models. So constantly being in touch with what's going on in the country and what our supporting organizations want to see, and where our practices need our support is how we will adjust and continue to provide a valuable program.
Great. Well, thank you all so much. I want to thank our excellent panel of speakers who took time from their busy schedules and all the great programs that they're doing to be with us today. And thank you to our audience for all your great questions. I'm sorry if we didn't quite get to all of them, but we are past 2:30 at this point. We will have the slides from today's webinar are up on our website, and we will be making an archive the event available if you'd like to share it or listen in again. And we really look forward to continuing to work with all of you to improve children's health, and hope the information today was useful to your own work and to spur ideas for future work and collaboration. So finally, please take a moment to share feedback from this event to us, and on behalf of NIHCM and the AAP, thank you again for your participation today.